Yeah, so firstly, good morning and welcome everyone to today's webinar on navigating EPR implementation complexities. So for those that don't know, my name's Heather Halliday. I'm one of the associate directors here at Keystream. And for those that aren't familiar with our business, I'd like to just firstly provide a very quick overview on who we are. So at Keystream, we empower public sector organisations by addressing their evolving needs through people-powered, tech-enabled solutions. Our recruitment and consulting services with a focus on digital data and technology are designed to help organisations make services more accessible, efficient, and obviously tailored to the communities that they serve. So with me today, I'm firstly joined by Richard Yaldren. Hi, Richard.
Hello. Thank
Hi,
you for
Richard.
inviting me.
Thank you so much for joining. So Richard is a seasoned program manager with a career marked by the successful delivery of transformation projects. Most recently, Richard served as Associate Director of EPR at Tees, Esk and Weir Valley's NHS Foundation Trust. Richard also has a background in business intelligence and developed solutions that enhance reporting and ultimately improved patient care. So today he'll share his insights on the importance of clinical engagement within EPR implementation, a topic he's particularly passionate about. Our second panelist is my colleague Andy Spence-Evans. Hi, Andy.
Hi, Heather. How are you doing?
Yeah, good, thank you. So Andy brings over 18 years of recruitment experience, including 16 years supporting the NHS across operations, corporate services, and digital data and technology. Andy is passionate about delivering dynamic solutions to NHS resource constraints while ensuring quality and value for money, particularly within digital transformation. So during today's webinar, we'll delve into the complexities of EPR implementation, including the importance of building the right team, the power of clinical engagement, and how to sustain success post-go live. I'll be posing a series of questions to Richard and Andy, and we'll have time to answer your questions at the end. So please do submit them in the chat, and we'll aim to cover as many as possible. So starting with our first topic on building the right team for EPR success, I'd like to firstly ask Richard. So Richard, what were the key skills and qualities that you looked for when building your EPR implementation team, especially given the complexity of the project and limited resources?
It's a very good question. I think I focus more on clinical, but obviously an EPR program is multifaceted and there are a lot of different skill sets needed. Obviously, you have the program management and a very good program manager with experience on how to deliver and keep us all, because it's a very passionate project as an EPR. So sometimes we can go a little off track, and you have a good project manager that'll keep you on track. And then there's the technical abilities. You can't get anywhere without someone having that technical skills. But as this is focused more around the sort of clinical engagement, I was very lucky to establish a clinical team that drove the EPR forward. I think it was probably an unusual one at Tees, Esk and Weir because we had the chance to build from the ground up. Sometimes a lot of EPRs are you're given a program, you're given a project, and it has a solution that's already made. So in Tees, Esk and Weir, it was very clinically driven, and that is something I was very passionate about. The skill sets we needed was a real can-do attitude. Someone who's sorry, there's a fly there, typical. There's a real can-do attitude, because it can get very tough. You're going into people's lives and you're saying, actually, we're wanting to change this, and we're looking at how we all work. There's a lot of variation in the NHS. It's a very dynamic place. It's very, very busy. So someone with that kind of understands those business processes and those clinical processes and can engage using clinical terminology is very good. Sometimes there can be a gap between IT and clinical, and the language can lose people. So using very plain sort of English that clinicians work. I would often go and demonstrate and talk, and I could see people's glassy eyes, and then the clinicians would go up and they'd all go, "Oh yes." So they're invaluable and I was blessed with some really good clinical people that led that. I think because it was a small team, there was very much you needed the ability to problem solve and come up with ideas, and that adaptability and being able to learn on the job, because it is fluid and you often build something and then before you know it, a clinical change has happened and you have to go back and revisit. All of that, your interpersonal skills, that collaboration and communication is absolutely vital, because there are those tricky moments, there are those tough conversations to have where, when for an EPR, you really want to standardize clinical processes. So that means some people will have to change the way they work, and in certain circumstances they might get less than they've already got now whilst at the beginning of the journey. So that empathy is really important. I mean, I could talk about this forever, but I'll let Andrew sort of continue.
Thank you. So Andy, next, so what key skills or qualities do you think trust should be looking for when hiring for a digital transformation project, especially in leadership roles?
Thanks very much, Heather. That's actually a really good question. I think, firstly, having the right leadership for any given digital transformation project can ultimately determine whether a project succeeds or fails. We often get asked by our clients for a number of key skills and qualities, and some of which might include leadership. And by that, I mean in the true sense of the word. So the ability to inspire and lead teams through transformation, and candidates that can foster collaboration and innovation. And effective leaders should be able to motivate their teams and build a culture that embraces change. Secondly, change management expertise, so crucial within digital transformation. As we know, digital transformation involves significant and complex changes in processes and business culture, and leaders should be adept at managing change successfully, ensuring stakeholder buy-in, as well as overcoming any resistance. Another really key point for me is technical proficiency. So while project leaders don't need to be hands-on technical experts, a high-level understanding of digital technology is crucial. So digital project leaders should be able to assess technology needs and make informed decisions about tools, platforms, and solutions that can positively impact the success of their project. Again, very important for this landscape and context that we're talking about is project management skills. So having proven experience in managing large-scale projects, including budget management, risk, and project milestones, is absolutely essential. I think senior leaders should be able to deliver projects on time and within budget, especially given the current economic climate. And then lastly, stakeholder engagement capability, and that's at all levels. So effective leaders will need to be able to engage with a diverse range of stakeholders, including clinicians, IT staff, patients, corporate functions, and external partners. And they should also be skilled in building relationships, negotiating, and aligning different and competing interests and priorities. Thanks, Heather. That's everything for that one.
Yeah, brilliant. Thank you, Andy. That was really insightful. So Richard, next. So often in the NHS, budgets are tight and resources limited. So can you share how you adapted your team? I think you might have touched on it a little bit earlier, to actually maintain momentum during the EPR implementation at Tees, Esk and Weir.
Yeah, the NHS is growing in demand and decreasing in finance, even though there is investment. So an EPR touches on many areas, and it's very, very complicated. I think you need some really good adaptive strategies. Underpinning any program, you need that good governance. So one of the things that we did in the Tees and Esk and Weir is we established a clinical governance that met weekly, sometimes it's fortnightly, and that included senior leadership, clinical leadership. And the purpose of that was to help us focus on the core deliverables, because you can touch every element on this, but it tends to be you've got to deliver at a point in time, and you can't fix the world in a day. So some really strong governance and project management. I mean, there is a theme there about that, but that transparency and really maintaining that sort of stakeholder engagement. Like I say, back to the adaptability, what I previously said is that can-do attitude. We had some people with multiple hats on. So sometimes, especially the clinical leads, they were leading certain projects and then parts of the project, and then they would have to do a business analyst. Then they were talking with the developer to sort of talk about that. So they wore many hats. And like I say, I was blessed that there were times when they're saying, this is not my job, because it can get very stressful.
Yeah, sure.
But it's about identifying, there are a lot of people in the organizations. The NHS you don't work in the NHS because for money and fame. Your work there tends to be because you love the NHS. You're really there. There's a lot of people in the organisation, so there were the developers. We managed to get involved. So we begged, borrowed, and stole at times to get people involved. Some of what I did was a real communication exercise around all levels of the organisation, presenting what the vision was and selling what it was about. And then I did have people contact me saying, I'd like to get involved. And then that led to sort of creating that, that stakeholder engagement, which we then built on. And when the clinical people were involved, they really built on that clinical engagement. So I think you've got to be very flexible. You've got to also raise it at such a level that the organisation can prioritise, because there is a lot of change happening in the NHS and there can be change fatigue. So it's about, as an organisation, what would you like to prioritise? And then to do that and to deliver this thing, these are the positions that we need help and support with. So we had quite a big virtual team as well.
Moving on then to Andy. So what do you think are the common pitfalls in securing the right EPR team, and how can they be avoided?
Brilliant. Thanks, Heather. Again, this is really relevant given the competitiveness of the EPR candidates market at this current time. I think, if we're keeping in mind the EPR implementation deadline set by the government, the EPR candidate market has become very competitive, with many trusts up and down the country simultaneously implementing EPR systems. Often NHS organisations are going to be competing against each other for highly sought after and specialist EPR skills. And the way I'd sort of position any solutions is that hiring stakeholders within the NHS should undertake market analysis, or at least have a good level of awareness when it comes to assigning budgets or daily rates against their resource needs, so they can keep themselves competitive. And they also need to consider how they can make the opportunities as attractive as possible in a competitive candidate market. Another pitfall, it can be, not for everybody, but poorly defined project roles. So without clearly defined roles, objectives or scope, team members may not fully understand the deliverables of their roles, and this leads to misalignment against project requirements. It can create inefficiencies and ultimately a lack of delivery and possible project failure. Again, a way to avoid this is to take time to scope out resource and requirements thoroughly, ensuring key competencies and required experience is captured to ensure adequate skill match against the needs of the project. And this is a really pertinent point for me, is how organisations engage specialist resource for their projects. Quite often, we're seeing organisations go to market with highly specialised EPR roles that could be better positioned, so making the opportunity much more attractive to the candidate market, and in turn attracting a higher calibre candidate pool. And for me, NHS trusts can make themselves more competitive in the way they position the hires, such as procuring services via a managed service or a consulting contract. Factors that would also typically inform the IR35 status or determination. Many of the candidates who offer highly specialised skills really only want to work outside of IR35. They will be running personal service / limited companies, and that suits their situation much better. And then leading from that last point, recent trends suggest that the NHS interim management market is going through a period of unconscious change, in that we're finding many more of our NHS clients are moving away from pure interim engagements and moving towards that model I mentioned of a managed service, or completely outsourcing the delivery and the financial risk of delivery to a delivery or consultant partner. Whereby the consultant partner will absorb the liability, assume the responsibility for building the appropriate team and resource, and ultimately delivering the agreed project objectives. And then lastly, another consideration is also offering remote or hybrid working options to make the role more attractive. I think everybody knows that, the working world has changed post-COVID, and organisations should identify with that change. But yeah, they're the sort of key points I've mentioned. Thanks, Heather.
Yeah, thanks, Andy. And yeah, absolutely right. I think that's the beauty of having different models. And I think does seem to be more of a trend toward that managed service offering at the moment, for sure. So moving on now to our second topic, obviously very important to Richard, which is the power of clinical engagement. So Richard, I'll start with you. So clinical buy-in is often cited as a challenge in EPR programs. How did you foster collaboration between clinical and digital teams, and what strategies help secure clinical engagement at TESC and Weir?
Another good question. I think for me, my approach, having looked at many projects that I'd previously done, is sometimes clinicians felt that projects were done to them rather with them. And that was a key theme that I held as a core belief. So first of all, you've got to get the buy-in. You do have to get the buy-in at the very top. So there was a clear sort of strategy and vision of what we was going to do. And I remember the slides of, I still remember them now, of what the key benefits would deliver. There was some of the patients felt very much, interrogated. They were asked a lot of questions and processes were disjointed. So some of the key benefits really was about how it was going to save time for clinicians, give them more time to care. So highlighting very key benefits that are pertinent to clinicians. The next thing was really an early engagement and as much as possible. So we ran a few events, we did some webinars. I would go to team meetings and strategy days, and again, just selling the vision and why it was really important to do that. So always maintaining that clear vision and communication. And once the clinical team was established, that used to blog on a sort of weekly basis. You can argue how successful that. It's very challenging to get clear communications through to a complex and busy NHS organisation. But you constantly have to keep pushing that. This is what we're up to. This is what we're doing. Because there is a danger with an EPR that there's a big fanfare that we brought this thing, and then it goes very quiet and no one knows about it. And it's 100% of your job and it's 0% of their job. So they continue daily on. So if you want to build that seed and grow the seed of like excitement and encourage people to do that. So we, like I said before, we did establish a good clinical leadership that helped with the decision making, but we also what they were called, like champions, or as you would say. You develop like a champions network, and initially you get those people that are keen, and then word of mouth. But there is very much that drive. I think to get the buy-in as well, you've got to really listen. Big eyes, big ears, small mouth, and listen to the clinical concerns. Because you can wax lyrical, and then someone is just sat there thinking, what does this mean for me? You're going to change my world. If you think about it, one day you're used to using a system for 10 years, and then the next day something's brand new. It's very daunting, that.
Of course.
So it is about listening to those concerns, and it's about trying to break them down. And not everyone's interested. An outpatient person might not be as interested in an inpatient thing. So we also categorized areas. So if you had a particular interest in certain things, there'll be something more about that. And I had clinical leads that specialized in certain areas, and they would take the forefront on that. So, and then we could run multiple sessions at the times. You can't really do an EPR in one big go with the communication. There's so many different factors of what needs to be communicated. So breaking it down, like that old saying, can't eat an elephant in one go, just do it in bite-sized chunks. And it's trying to make it break down. And if there are, you've got to be very agile and sort of have that iterative approach, and then communicate any early successes. So we redesigned the referral process. I think one of the things looking back I could have done better would be that really sort of emphasizing the successes. Clinical services came together and worked together and developed a process that they're all going to work. That might not sound like much, but actually in the NHS was really, really big for our organisation. It was a big, huge thing, and we could have celebrated that more. And I think that that leans itself, because they've been involved in the process and they've been helping design, leads into that more sort of willingness to embrace this when it comes live, and that long-term engagement.
So Andy, over to you next. So for those looking to enter the NHS digital space, what key skills or experiences can help candidates demonstrate their ability to encourage clinical engagement and build strong cross-functional teams?
Thanks, Heather. Again, the really important elements of digital transformation, especially given clinicians and different teams across any organisation are often heavily involved in the use of clinical systems. Some important points for candidates to consider might include highlighting cross-functional collaboration, so teamwork examples, highlight how you've how you've worked effectively across cross-functional teams, including IT and technical, clinicians and corporate teams, to resolve issues and implement solutions. It's also worth emphasising your role in fostering collaboration and facilitating constructive communication. And then conflict resolution, you might want to provide examples of how you've managed conflicts or different opinions within a team to reach a consensus or a solution. So important, when working across cross-functional teams. Secondly, showing an understanding of factors that motivate clinicians to make changes to the way they work within a digital transformation context. So it's important for candidates to demonstrate they identify what's important to clinicians and what motivates them to move away from traditional working practices. So, for example, will it benefit the patient or provide improved patient care? And if so, candidates are much more likely, when tapping into those drivers, to have positive clinical engagement. Also, candidates who can show a track record of delivery and demonstrate positive clinical engagement in past assignments or roles will definitely be well positioned. A real simple point, but so crucial, is effective communication. So clear, concise and tailored communication is crucial. I think candidates who can articulate the benefits and impacts of a project or program in a way that resonates with clinicians are often much more successful. And that really includes listening actively to clinicians and concerns and feedbacks and adapting your approach accordingly to take those into account. Again, something that's key when we're talking about clinical transformation is strong experience of change management. So navigating the complexities of change within the healthcare setting, which really requires strong change management skills. I think candidates who are used to managing resistance, understanding the dynamics of change and guiding teams through transitions are generally more effective. And then finally, and this is a real key point, given that we're living in the information age, is data-driven decision making. I think candidates who can analyse data, present findings clearly and use evidence to support their recommendations are much more likely to gain stakeholder buy-in and engagement, if it can be backed up in evidence with hard data. But yeah, that's how I'd summarise that. Thanks, Heather.
Thanks, Andy. And you obviously both make sort of key points there about active listening, and it just shows how important that is, particularly in programs of this nature. So a final question then for Richard. So on this topic, so during your recent EPR implementation, obviously where clinical engagement was critical, how did you encourage clinical staff to embrace new digital workflows, especially if there was resistance? Because obviously you touched upon that earlier, but how did you deal with it if there was resistance?
Yeah, I think Andrew might have been looking at some of my key pointers as well, because there's a lot of synergies there. I was, like I said before, I was blessed. I had some really good clinical colleagues, and they bore the brunt of that. And one of the things I discovered early on is I could say all the right words, but it's very important who is saying those words. So when I got the clinical lead involved, when she was saying what I was saying, people listened more. So I think having senior clinical people, and if you can establish like a permanent clinical team for the project, like full time on there, they can really help on that, because it is about listening to concerns. But I guess, how can I address a clinical concern? Because I might not fully grasp what it is that they're doing. How, as a fellow clinician involved in that, can really grasp. And there were many times when it was explained to me in, I guess, dumbed down for me, so I could understand what the actual impact of that meant. So then we can make clearer, better decisions on there. So really, again, back to that big eyes, big ears, small mouth, really listening to those concerns. And we had open forums, and they were clinically led. The clinical leads would lead a lot of that, and they would have conversations. And as ever, it is that listening. And if there are specific concern services, they would go to specific meetings and really list those up. Of course, your governance, your project management highlights that, because you've got your risks and you highlight these things. So potentially bringing in a new process might affect X, Y, and Z. I think, again, it is a lot to ask for people, and it can be quite draining because it's constantly like that. So getting clinical champions and being able to sort of have a wealth of other people involved is a really good approach to have. And what we did do, what the clinical leads did, is that they got people involved. So they'd go to the specialist. So if it's physical health, for example, they would go to the lead of the organisation and that team, and work with them to design the clinical process and the workflows. And then we would draw that up. Again, they had to draw that up because we didn't have the business analyst skills. Again, there were, multiple hats. This was that adaptiveness. But then we'd feed that back, and then that would go to the clinical leadership for sign off. So what that basically allowed us to do was listen, redesign with their help, get it clinically signed off, and say what we're delivering here is what you've been involved in and what you're wanting to do that. So when you do hit those resistances, you can say, well, this is actually, we're not doing this to you, you're doing it with us. It's that approach again. And it's that really, I guess it's that involving them and just having really thinking about, back to my previous point as well, is how do you then, because not everyone can be involved. For some people, they don't really understand what the first process is. So we did do a lot of tailored training, and what we did do in the system was break down, and we had a thing called like gold guidance, which explained why it's really important to work this new way and what a good example was. And then there were how-to guides that if you were stuck, but the idea, they were integrated into the system, so you didn't have to go away. Everything was like 1 or 2 clicks away. How successful that has been, is waiting to see. But the idea was to be as transparent as possible, show your workings out. That it's not secret, and then show what the engagement was. And hopefully that starts to develop that culture of digital involvement and innovation, because people are involved in something and then they can see it to fruition.
Yeah, brilliant. Thank you. And I think, both of you really highlighted there not only why clinical engagement is so important, but actually how to achieve it, which is, hopefully really insightful for everyone listening here today. So moving on to our third and final topic for discussion, which is post go live and actually how to sustain success. So I'll start with you, Richard. So what steps did your team take post go live to ensure the sustainability and long-term success of the EPR, particularly in terms of staff engagement and system usability?
Yeah, I mean, I'll be honest, it was an EPR is, like I say, is a complex project, and it started off really well and then it didn't go so well, and it was very challenging. But what emphasized what the clinical team and myself had achieved was that we still had the buy-in from the organization. Clinically, they were with us, and I'm not gonna, lie, it was tough. And
Yeah.
I've noticed that as Jenny's joined from Tees, and she was a major factor in the success. I'm hoping it's still working and going well. But I think basically we were very honest and transparent. And when it wasn't going so well, it was not down to the clinical work and the clinical design. It was more down to the capability of the system. And then you try to really work out what the impact's going to be, but there's nothing like a go live. So one of the things that we did do was completely ongoing support. We had like a Teams calls that were open all the day, so people could join in and access, and created an AI bot which we loaded it with lots of information in. So if you were that way inclined, you can ask the AI bot, and they answered over like 12,000 questions. But wow. there was a regular feedback mechanism, and the trust was very good at this. It established a goal command and other commands, and it fed back to the teams that were having problems what the ongoing issues were, and it was very, very transparent. I think some of the things that we'd put in place, like the weekly clinical leadership thing, they stayed in place and they were involved. So a lot of the pre-work actually really benefited when we went to go live. Again, you still need that prioritization mechanism, but rather than the project and the program team prioritizing, it's very much to the organization. What are the key concerns? What do we need to address? Obviously, above everything is clinical safety. That drives those things. But again, to maintain the ongoing support, you've got to set your benefits early in the day, and it's about monitoring those, having some sort of KPIs and reporting outcomes that you feed back about how well we're doing, completion of notes or care plans signed off or whatever it is. It's that constant communication and maintaining that leadership. I think for for an organization, the EPR project starts once it's gone live. For the program team, it's been full, but for the organization, once we go live, that's the first time they get their hands on it. That's when things you may not have thought about come up, and then it's maintaining, I guess, for at least for a while, that project sort of mindset, that regular prioritization, having meetings, discussing key things, and being very transparent with the communication and feedback about what has been done to address concerns or any problems and issues.
What advice would you give NHS organisations about retaining staff to manage and sustain EPR systems after the initial implementation phase?
Brill, thanks, Heather. I think there's a number of ways that trust can utilise that they can utilise to increase retention of key EPR staff. And some of the things to consider for me are offering ongoing professional development. So, if we're talking EPR training and certification, provide continuous training opportunities to keep staff updated on the latest advancements in EPR technology and best practice, support certification programs relevant to EPR systems and staff roles to keep employees engaged and retained. An obvious one, but career progression. Create defined career pathways within the organisation for EPR related roles and offer opportunities for advancement and specialisation in different areas like data management, analysis, system integration, configuration and development. Another simple one, but provide competitive compensation. Ensure roles are appropriately banded, within the structure, and be competitive with neighbouring trusts that sit within the region. I think often we see senior roles within the NHS which aren't appropriately banded to the level of responsibility the role carries. A simple idea, but foster a positive work environment. So recognise and reward staff for their contributions and successes. And I think Richard touched on this a bit. Implement formal recognition programs and celebrate achievements. And I know this can be difficult in senior roles, but creating work-life balance. So a few ideas with that might be flexible hours or hybrid and remote working to accommodate different people and lifestyles. Again, another point I would sort of recommend is encourage and facilitate knowledge sharing. Again, Richard touched on it quite a bit there in terms of lessons learned. What have we done well? What have we not done well? Constantly engaging with the workforce. So share that knowledge, create forums where staff can share knowledge, discuss challenges and collaborate on solutions related to EPR systems and have their input and say to gain that involvement. Mentorship and peer support. Establish mentorship programs where experienced staff can guide and support newer or less experienced colleagues and prepare them for the next step up in their career journey. And again, this is great for succession planning within the organisation as well. My final point on this will be invest in effective tools and resources. So having the up-to-date technology to ensure that staff have access to the latest tools and resources needed to manage and support the EPR system efficiently and effectively. And again, a real simple point, but providing adequate support staff such as admin to reduce burden on highly specialised technical staff to allow them to focus on the critical tasks. But yeah, that's what I'd sort of say on that one. Thanks, Heather.
Yeah, thanks, Andy. And obviously, like Richard said, with building that bot, it's like providing that ongoing support, isn't it? Which is an amazing tool for people to access. So kind of sticking with you then, Andy. So as digital teams continue to support an EPR system post go live, how do you think candidates can actually demonstrate their adaptability and problem solving skills to sort of thrive in these ongoing roles?
Okay, great. So yeah, there are a number of ways candidates can demonstrate these competencies. So showcasing problem-solving examples. So highlight relevant experience. So share specific examples from past roles where you've successfully identified and resolved complex issues, and maybe highlight instances where your problem-solving skills have led to improved outcomes or efficiencies within that role or project.
Sure.
Secondly, I think something which is really key is emphasising your adaptability through continuous learning. Ongoing education and training is so important in this sort of ever-changing and evolving world and landscape that we live in. I think demonstrate a commitment to staying current within industry trends and technologies related to EPR systems. And this could include undertaking relevant certifications, qualifications, and attending workshops or networking events to keep yourself current. And also really important is learning from feedback. And I think this is probably underrated, but provide examples of how you've responded to feedback and used it to improve your approach or skills. And adaptability often involves learning from experiences and just adjusting your approach accordingly. Again, really important in this context is experience with change management. So handling change, share experience where you've successfully managed or adapted to changes in processes, technologies, or project scope. It's worth describing how you've handled this transition and supported others through the change. I think that will stand you in very good stead, when you position yourself for new opportunities. And change implementation, for me, it's about giving real life experience of how you've contributed to implementing new processes or systems. And this could include how you've addressed challenges which led to a smooth adoption, something that Richard touched on. And finally, highlight your technical proficiency in problem solving. So demonstrate your technical skills related to EPR systems, such as troubleshooting, whether it's system configuration, data integration, or any specialized area that you've held roles in before, and showcase any relevant technical projects or certification related to that. But yeah, cheers, Heather.
Brilliant. Thanks so much, Andy. So our sort of final question for today then, Richard, sort of goes to you. So what factors or innovations are actually crucial for ensuring long-term improvements in patient care through EPR implementations? And how can certain features contribute to sustaining these improvements?
Yeah, I mean, it is a meaty subject, to be honest. So we've got several hours. But I'll try and touch on a few. I think, the NHS is there for patients. So I think technologies that can improve patient access to their own records and their own care are pretty vital, and it would be up my, top of my list, such as patient portals or apps and things like that. I think, though, they still sometimes need a lot of help on how to use them. So that intuitiveness about what care you're being given, and then sort of transparent sort of patient-centered sort of flows that you can easily share. So technology that makes it really easy to say, I don't know if I'm going to go for a knee operation, this is what I can expect to happen, and really explain that. And a facility of being able to ask questions. Now, I don't see why, AI built into those platforms can't access and answer a lot of the questions. The power of AI is it can use multiple languages. So, a lot of people, English isn't their first language. So thinking of technologies that takes that communication barrier away is really important. And AI, that's one of the things that we introduced. And I had a developer that was fluent in German, so you could talk to it in German and it responded in German. But as the organization, they only needed to feed it, I guess, English. So you didn't have the overhead of lots of translation, and it's real time and it's natural language. I think with a lot of these things, technologies that learn, you can analyze what's going on for the processes, and then so you can make data-driven quality decisions around safety and patient improvement and health. So integrating your EPRs with your reporting solutions or your BI solutions is an absolute critical for me. The next step from that is taking those learnings and being able to feed them back into the EPR so that it can learn to say, actually, maybe when you make this decision, there's an 80% success rate, or is a 20%. So not only just having, because at the moment, I think there's a lot of reporting is separate from the end user, and if you're maybe in the management or you're into those, you can read that, but it's about integrating, so you have that circle, so you're putting the data in, and then the clinicians are getting the benefit It's not to take away clinical decision making. That's really, really important. And AI has to be treated with, it's not the you know, the be all and end all. It's going to solve everything, but it can be there as a, you know, phone a friend. It's really friendly to help back up maybe when you're thinking. There is a lot of information and data in the NHS that probably isn't as used. So joining other organisations and looking at that sort of public health information and how you look at what's going on in other factors like social areas and stuff that can impact the NHS and how you build those up. And I think just really to end on that, whatever it is that you're doing you need to really think about that patient-centered, user-friendly design. So you can get, and I can get very carried away with it, but if I've got this brilliant thing, but people can't really get past the first one or two screens, it's not going to engage people. You're not going to get those benefits. So taking some time, and what we did well with in the EPR and T's Ask and Weir was we engaged patients in the process as well, and they helped design things. We've got this brilliant box which is called Useful Stuff, because we were trying to come up with all these clinical words, and the patient said, well, isn't it just useful stuff? And that's what we called it. It's my favorite thing in the whole EPR.
Nice,
but it's a good example of having patients involved in what it is you're developing, because ultimately they're going to be the beneficiaries of that.
Yeah.
Thank you both. Really insightful, and hopefully has given everyone a bit of an overview. I appreciate that EPR is a very, very vast topic, and we've mentioned just a couple of points sort of within that. So there is obviously lots more to talk about, but I feel we'd be here for many an hour if we covered everything. The one thing I did want to say, which probably just from reading the Q&A, and I think it's probably important for you, Richard, is someone's just made a comment about it would be interesting to touch more about data quality and migration, both pre and post go live. So I don't know if you can share your learned experience and lived experience from T's Ask and Weir and how you went about that.
Yeah, we were lucky in T's Ask and Weir because we had one PAS system. Now, a lot of acute trusts have lots of different departments. They have the benefit of fewer sites, but the disbenefit of many departments with their own systems. So data migration, you have to create what's called a unique key so you can join that in. What we also had is we had the old system available in read only, but we identified via the clinical routes, again, what was the key information that people needed to see on day one. And we migrated all of that. Now, what we did is in the old system, we converted all of the documents into PDFs so they were readable. And then what the system did was then turn that into searchable. So data that was unsearchable in the past suddenly became digital and you could search for it. And we also then categorized it. But what we did is we resisted the urge to have 50, 60 categories, and we put them down into like 12 with maybe subcategories, because there's no point digitizing all this data and migrating it in if it's then not accessible and easy to use. What I would say is data migration is complicated, and if you're pulling from an old system, data quality will be questionable. So don't underestimate the length of time it takes that. Something that we did, and we were still migrating data, you know, many months later on. But what we did is we prioritized the first 2 years recent, and then we would roll in the next 2 years and the next 2 years. So the focus being on the most recent information is really important. But in mental health and learning disabilities, that's not to say historical data is not important, but you know, you want to make the clinicians need to make decision on the latest information. So make sure that is in first and have it clinically checked.
Yeah, brilliant. Thank you so much, Richard. So yeah, again, someone's just like to sort of raise about training of end users, and obviously that's has a huge impact. So how did you go about that when you were at sort of T's Ask and Weir again, Richard?
Yeah, we created a platform, and the first because the EPR is a culture change and it's an ethos as well, and it's that the trust was faced with quite a lot of challenges around, you know, having a single care plan and a single safety plan, putting the patient at the centre of care and being collaborative in their care plan. The first few training courses that we released earlier was very much about what the ethos was and what the culture is that we're moving towards. It is very challenging. Hospitals are running at vacancies and sickness rates, and it's often it's challenging to fulfill positions and roles and things. So you've got to, what we did was very much online learning that people could dip in and dip out. Ideally, what we'd have liked is a system once it was earlier to play with, so you can go in there, because and we created videos as well. So I'm a person that likes visualization. Other people like to read the details. So we tried to supply both in such a way on this digital platform. And again, linking back to what I said previously, we put how-to guides and goal guidance into the system, because it'd be very unfair to ask a clinician who's coming to look after patients to learn a brand new system by watching a video once or whatever, and then remember it maybe 3 months later to do the job. So the first part was very much awareness, and the training online was very much of this is what's coming and this is how it'll work. For me, it's kind of like just giving some awareness of what's going on. Then it's making that online training available. And then if there were trends that maybe were highlighting from practice, there would be messages to go back to say, don't do it like that, do it like this, and this is the reason for it. But I think training needs to be monitored ongoing and reflected and broken down into bits. So if you've got 10 minutes with a cup of tea, you can do a bit of section of that, but always in your mind that you don't just learn something once. It's really you learn when you've got your hands on. So if you can make available an area, we were unable to do that you can play around with. We did get some people to do that, but that is one of the challenges. If you can do that, that's a really good approach.
Yeah, the training, brilliant, thank you. How were expectations managed when the new EPR platforms were rolled out for end users? So again, probably for you, Richard.
I don't know if you can manage everyone's expectations, and I think it's you're allowed to have high expectations. I think for me, it is a case of that transparency in the communication, like I've said before. And it's that feedback of so if you've got your data and you've got those things, you can feedback what is happening, what the improvements are. But again, clinical engagement is absolutely crucial from the beginning, middle and the end. But an EPR doesn't end, it just evolves. So I think maintaining a good clinical core of champions and experts and a good clinical team. Personally, for me, I would have a dedicated clinical team for the EPR. It's that important for me. And being able to feed back, and again, back to the big ears, small, big eyes, and listening to what's going on and feeding those back. Because sometimes the expectations are there and they have been met, but people are unaware of it because, like I say, communication is very challenging. So you have to, again, celebrating your wins by doing that. Potentially, you're also posting things which people say, oh, I didn't know that could happen. And again, maybe running events and things. But I think people's expectations change and are continuously there. So it is that continuous engagement that's really key to continue.
Do the Tees, Ask and Weir Valley clinical teams feel that they own and are responsible for the EPR? Is it their medical record system supported by digital, or is it still seen as IT?
I would say, and there is one of the ladies on the team, she might be able to back me, that I would say that they very much do own it. I mean, I was very much told at certain times, it's not yours, it's ours. And one of the examples is I designed the EPR front end and it was all nice blues and greys, typical sort of IT. And then the clinicians looked at it and said, well, that's boring. So it had a complete facelift and it's got multicolours. And what we used, I think it's really important, it's something I learned from them, was the use of icons and colours and things. So everything to do with care plans was yellow. So the forms would be yellow things. So it's not. So then it's also for people that you can say, well, the yellow forms are care plans. So it was clinically driven. I mean, it did lead to some challenging conversations, and I'll be honest, I do miss some of that back and forth. But you're a team when you're doing this, so people have different things. I would absolutely say that, but that only works if you really do listen to your clinical team, and the organisation gives the space for the clinical people to be involved. again, I was very lucky. I had some very good clinical people that were engaged and were permanent on that. And there were times they were off and they were doing things and I had to play catch up. So I do really, I would honestly say that I think that for me is one of the things I did do well and was managed to get that clinical ownership.
Fantastic.
And that was really, really paid off, well, like I say, when it's challenging at the end. And because there will be challenges on Go Live. There's no two ways about it.
Yeah, of course. Brilliant. Well, thank you so much.
Fantastic.
I think that's kind of all we've got time for today. But again, thank you to our panel. Thank you to Andy. Thank you to Richard. And thank you so much for everyone that joined today. And yeah, hopefully we've given you some insight and to take away from. Thanks so much, everyone.
Thanks for joining, guys. Thanks very much.
Thank you.
Thank you.
Cheers.
Bye-bye.
Bye-bye.